Hello. Thank you very much, Murray. Pleasure to be here. Those of you just coming in, there's some seats down here. If you don't mind crooking your neck a little bit. Have to look up. But there's plenty of seats down here. So I'll be discussing today a bit, as the title suggests, the diagnostic overview. With respect to specific questions about diagnoses, we can return to those in a breakout session for those of you who have additional questions. And I'm going to leave some time for questions at the end of this 20, 30-minute talk. So what's frontotemporal dementia? Well, this is just obviously a rather cursory description. So just to make sure we're all on the same page. So what is it? It's a gradually progressive disorder that involves specific brain regions. I got my only slide of a brain is going to be next. So I'm not going to torture you with pathology and all this stuff that Dr. Grossman knows so much about that I don't really know that too much about. So I'm not going to show you all that. But I will show you a brain because it's a brain disease. It's a disease that affects a specific part of the brain. The major changes, and this is Coles and Newcastle for some of you, the major changes are not in memory, for example, as you see in Alzheimer's disease. They're in personality, behavior, language. So it's a different disorder. And it primarily shows up with disorders of functions that have to do with the front of the brain and the temporal lobes. Another important aspect of the disease is the median age of onset, 55. Okay. Median age of onset of Alzheimer's disease, 75-ish. I don't know if that's exactly right, but somewhere in there. It's a disease that affects middle-aged people for the most part. It can start in the 70s. It can probably start in the 80s, but it's quite uncommon. It can start in the 20s, 30s, 40s, 50s. So it's a young onset, young person's disease, unfortunately. Okay, so ignore this. That's got nothing to do with anything. So, well, it has to do with something, just not frontotemporal dementia. I couldn't find the slide I was looking for. And since I'm a compulsive tinker, at 7:30 in the morning, I put the slide in. So imagine there's a nose up there, okay? So this is a brain. So when Pick described this, this confusion about what's Pick's disease, what's frontotemporal dementia. Arnold Pick, a brilliant neuropathologist, clinical neurologist in the early part of the 19th and then into the 20th century, described this disease around 1894. I was asking people before about what the exact date was, and nobody could tell me, but sometime around 1894, which, by the way, 1892. Thank you, Dr. Gussman. Okay, so 1892, that's about 15 years before Alzheimer described Alzheimer's disease. So it's a curious thing. Alzheimer's disease is far more common, as I'll show you in the next slide. But this was described 15 years before by this really, really smart guy. So what did he notice? Well, he described a patient who had these prominent behavioral changes and whose brain, when it came to autopsy, showed changes in this frontal lobe and the anterior portion of the temporal lobes. That is the part of the brain here and sort of underneath your ears, the front part of the brain. And this is quite distinct from the changes in Alzheimer's disease, which tend to be actually sort of around where this is, more in the back of the brain. So it's a difference between a front of the brain problem and a back of the brain problem, with the distinction between frontotemporal dementia and Alzheimer's disease. By the way, frontotemporal dementia is a more generic term. When Pick described the neuropathology of his particular patient, he described Pick bodies. You need to see these kinds of specific changes in order to make the diagnosis of Pick's disease. If you don't see that and you see the other changes that go with this, and you'll hear more about this later, then it's frontotemporal dementia. So Pick's disease is one of the subtypes, one of the variants of frontotemporal dementia. It's not a separate disease. It's a part of the broader entity that is known as frontotemporal dementia. So that's always often a point of some confusion. I hope that clarifies that. But remember, it's a front of the brain, frontotemporal, temporal lobe, anterior portion of this temporal lobe. Usually both sides. It can be more on one side or the other, and that where it shows up first, where it affects first, is what is the cause of the different types of symptoms. If it shows up, as we'll discuss, primarily in the frontal lobe first, then people have symptoms that differ from those patients for whom the disease primarily affects the temporal lobe. So, just to give you a sense of the prevalence of this, it's only too common, as you can all attest. You're here because of a reason, presumably. But if you look at 100 patients with dementia, this is based on an autopsy series, so this is really the gold standard. 100 people with dementia. It's one gold standard. I mean, different studies showed slightly different numbers, but about this is about right. About 2/3 of them will have Alzheimer's disease. Frontotemporal dementia is not that uncommon. In various series, it ranges from 5 to 10% of patients who are seen in a university setting go on to have an autopsy, and when they have the autopsy, turn out to have one of these conditions that I'll be describing. So it's gotten a lot less attention. I'm not that old, although Dr. Grossman kindly described me as a senior cognitive neurologist. I don't think of myself as that old. But when I was a resident, people said, oh, this Pick's disease, you'll never see it. It's amazing. They just said, oh, you know, it was described and it's really rare, but you might see a case or two. Unfortunately, we're seeing a lot more than that. It's far, far more prevalent than people recognize, and certainly underdiagnosed. You guys probably know from experience that most people with frontotemporal dementias are given the clinical diagnosis of Alzheimer's disease. Yeah, so it's people, there's still a sort of emerging understanding of the clinical aspects of it, and it's often misdiagnosed. Okay. Forget that. I don't need that. I'm going to go through. I don't want to. I have a tendency to start rambling, and I'm going to have to watch my clock here. So, what are the most prominent behavioral, most prominent symptoms early in the course of frontotemporal dementias? Well, I think most of us would agree that changes in behavior of the various types that I'll describe are probably the most common initial presentation. The problem when you start doing these kinds of lists of the kinds of changes in behavior, they encompass everything. So these lists look really boring and dry, and every kind of change in personality under the sun gets on these lists. But the real sort of crucial thing is, from my perspective as a clinician, I think the other clinicians in the room would agree, is that it's not necessarily what the change is, although that does have certain importance. We'll come back to that. It's the fact that this person is no longer behaving the same as they were. It's not so much the nature of the change. It's the fact that Mr. Jones is no longer Mr. Jones in the same way. He's behaving differently. If he was a bellicose, sort of difficult, ornery guy, he may become calm and even apathetic. Somebody who's apathetic may become disinhibited, overly outgoing. It's really, so again, the specifics of the change are secondary to the fact that the person's behavior is changing in a fundamental way, something that's just not right for them. And if you look at the specific kinds of patterns, what you see is obsessive behaviors often creep in. So people start becoming obsessed with stamps or obsessed with posters. It can vary. But really, I mean, sort of an unhealthy interest in a specific topic. Apathy, lack of insight is characteristic. It doesn't differentiate FTD from many of the other dementias in which lack of insight is also very common. But most patients with this kind of condition don't really see that they're not the same. They don't really they don't just get it. Emotional volatility, this kind of up and down kind of wild fluctuations in emotional behavior really is quite characteristic. The other thing, the other sort of misdiagnosis that I have seen on a number of occasions, and I'm sure Dr. Grossman has, is that FTD can be mistaken for psychiatric disease. So a fair number of patients that I have seen over the years have been referred by a psychiatrist after a number of medicines didn't work, or the patient was being followed for a year or two, and their changes just didn't seem to evolve into a typical pattern. It's often because of this kind of emotional volatility. Sometimes people are given the diagnosis of bipolar disorder, so-called manic depressive disorder. So that's, you know, one of the common sort of initial routes that people go is to see the psychiatrist who thinks it's a primary psychiatric as opposed to neurologic, a distinction which we could argue about if it's even relevant, but often are referred from psychiatrists. Okay, so well, we'll come back to this. I'll give you a chance for some questions. But so that's all I was going to say about the behavioral changes. They're prominent, they're early, they're often the presenting complaint, and the nature of the behavioral changes isn't really as important as the fact that the person is fundamentally altered in terms of their behavior. The other sort of, I think, major domain that's affected early in the course of various forms of frontotemporal dementia is language. And characteristically, the first problem that people notice is so-called word-finding problems. And all I mean by that is that people find themselves a little bit less articulate than they had been before because they can't come up with the right word. Now, this is the kind of phenomenon that everybody's experienced at one point or another. We've all gotten in the middle of a sentence. I've done it 3 times here so far, and no doubt will again. If I only do it 3 more times, I'll be good. But you get in a sentence, and you're saying, oh, man, what's the word I want to get? It doesn't come up, and you sort of work around it, right? So you define it. You give it a little bit of a definition. You go around it a different way. You come back to the idea. But these kinds of word-finding problems are very, very common in frontotemporal dementias, and usually the first symptom of language disorder. It can be, there's sort of 2 variants of this. In some people, it's word-finding problems because the concept is lost. They're really sort of losing the sense of the meaning of the word. In other people, it's word-finding problems because they understand the concepts fine. The word itself, the sounds of the word, the so-called phonology, just doesn't come. And and people will often substitute words. So this is just the usual sort of jargon that we use. But these are semantic paraphrases and phonemic paraphrases. So basically, these are sort of different ways to have problems coming up with words. So if you substitute table for chair, we refer to this as a so-called semantic paraphrases. People often just get the word wrong, and then something comes out, but it's just not exactly what they meant. If you butcher the word, like I habitually do, then you get to these, I didn't mean to do that, actually. You get, there's too many buttons on this thing. I got to get my hand away from that back one. So you get things like when people are meaning to say flag, or you show them a picture of a flag, they say fliggle. So the sounds come out sort of wrong. Now is when I meant to move on. Let's see. As the problems progress, you get more and more problems with language, so that people often have problems not only producing words, finding the right word, but understanding words. They have problems with reading and writing words. And this is probably worth mentioning because this is a relatively common problem, particularly in one of the variants of frontotemporal dementia to which I'll return, and it shows the nature of the nervous system in an important sense. These diseases are characterized by the loss of so-called stored information. What I mean by that is, stored information is you've learned stuff. It's in the brain. It's stored there. You have to have stored information in order to read that word as so. It's not complicated, except it shouldn't be pronounced that way. Look at it. That should be Sue. There's no sense from that. And look at that. That's ridiculous. I mean, show me the way, tell me the principles according to which this sequence of letters comes out as kernel. How about O-N-E? 1? We have 20% of the words in the English language for which the phonologic correspondence can't be generated from the letters. That is, they don't make sense. You got your kernel. Okay? You need stored information about this. You have to know that that equals kernel. People with frontotemporal dementia, and particularly the semantic dementia version of this, start to lose that information. And what do they say to that? Colonel. They retain these wonderful skills at sounding things out. So you show them, I didn't put it on this slide, you show them words like arbitrary, which can be sounded out, but it's a pretty weird word. It's a pretty unusual word. People read that perfectly. So it's this loss of stored information in these disorders. As the condition progresses, you tend to get perseveration or repetition of the same word. And often you'll see this phenomenon of echolalia, which means that people will repeat back to you what you've just said. So you say, how are you? And they say, how am I? Or how am I today? So they often incorporate part of what you've said into their utterance back to you. It's referred to as echolalia, described by Pick 100 years plus ago. And often with frontotemporal dementia, eventually people simply become mute. Just don't produce words. It becomes more and more difficult producing words. The representations, the sort of stored knowledge that underlies the words degrades, and people really stop talking in many instances. Now, again, the variability in this disorder is enormous. This is not to say that this happens to everybody. I can't tell you there's one thing about one clinical behavior that occurs in everybody. It's hugely variable for reasons to which I will return if I talk a little faster, because I've got to get through some of this. Okay, so these are the so-called cognitive symptoms. I mean, one of the prominent things that you see is distractibility. People just can't keep their mind on the same topic. So in this course of a 2-minute conversation, they've addressed 3 different things. You're sitting having a conversation, the door slams 3 rooms down, and they attend to that and become distracted by what that was. So this kind of phenomenon of failure to maintain yourself in the same kind of set, to maintain failure to focus on what's at hand is a very common problem. And this is, in a sense, the same kind of thing as this cognitive inflexibility. Planning becomes a problem. People make a lot of problems planning with their finances, even if their mathematical skills are terrific, a point to which I'll return again. Okay, and the other thing I meant to put on here, but I didn't, is memory. And I meant to put that on there because paradoxically, or maybe not paradoxically, but memory, in the sense of day-to-day memory, is pretty darn good in many people with frontotemporal dementia. If you look at memory according to California verbal learning test, where you give people 16 words and you say, we're going to repeat these 16 words, people don't do too well on that, but that has a lot to do with the problems with words. But memory in a day-to-day sense is often pretty darn good in frontotemporal dementia, whereas it's impaired in a dramatic way early in the disease in Alzheimer's disease. So day-to-day kind of memory is really not so bad in many people. Okay, I'm not going to go into this too much other than to point out these are the sort of things that you see on the examination. Forget about primitive reflexes. Incontinence is self-evident, so people often lose control of bowel or bladder, but this tends to be sort of late in the illness in most people, not in all instances. So there are these kinds of things, this akinesia, rigidity, and tremor, by which sometimes are referred to as Parkinsonism. It's not Parkinson's disease, and we don't need to go into the distinction between Parkinsonism and Parkinson's disease, but these are the features where people tend to be stiff. They tend to have a paucity of movement, so people tend to blink less. If you look around you, you're bored today, look around at people blinking. They generally blink 14 to 15 times a minute. People with frontotemporal dementia may blink 5 times a minute. They just don't move. All this grooming kind of stuff, you look around you, people are doing this, they're doing this. You know, people change. They move all the time. Many people with FTD don't. They sit very still. And it's sort of eerie. These are the things that people say, that person's got Parkinson's disease. It's not really Parkinson's disease, but it's a paucity of movement, which is designated an akinesia. Tremor can be present, not too common, but can be present. Now, we'll also come back to the fact that ALS, so-called Lou Gehrig's disease, is observed in some patients with frontotemporal dementia. It's not real common. In fact, it's pretty uncommon. I don't know exactly numbers, and where's Jennifer Farmer? She could tell us the numbers off the top of her head, I suspect. But it's relatively uncommon, but certainly can be seen in one variant of frontotemporal dementia. Okay, so when we see a patient with frontotemporal dementia, or a patient with a dementia, one of the things that as a clinician we're trying to do is differentiate frontotemporal dementia from the more common disorder of Alzheimer's disease and some of these other conditions that I won't mention today because they're not the topic today, but corticobasal ganglionic degeneration, et cetera, some of the other kinds of conditions. So there have been a whole bunch of studies that have investigated the behavioral changes, the sort of things that clinicians can observe that help to differentiate frontotemporal dementia from Alzheimer's disease. And this is just one paper that was published by Neary and colleagues from Britain, but there's been a whole bunch of other ones that show similar kinds of things. If you look at, and this was based on autopsy patients, so the diagnosis is pretty clear-cut. If you look at disinhibition, by which, does everybody know what I mean? That disinhibition means you fail to modulate your behavior well. So if somebody says you can't have that, people fly into a tantrum as opposed to saying, oh, come on, let me have one cookie. That kind of really volatile behavior. So disinhibition, 0 of 19 patients with Alzheimer's disease, 14 of 20 patients with FTD. So it's far more common in frontotemporal dementia. Weight gain of 20 pounds or more, 1 of 19 patients with Alzheimer's disease, 14 of 20 with frontotemporal dementia. So eating habits become very altered in frontotemporal dementia frequently. People develop sort of real strong preferences. You know that joke about somebody's pregnant and all they'll eat is pickles? Well, some of these kinds of things are observed in frontotemporal dementia. So people really develop very specific and really ingrained habits about what they're wanting to eat. Apathy, 19 of 20 patients with frontotemporal dementia, 19 of 20 versus 4 of 19 with Alzheimer's disease. Loss of social skills, another way of saying these kinds of behavioral changes. 1 of 19 in Alzheimer's disease, 19 of 20 in frontotemporal dementia. Now, this is a little bit less, okay. Many of you have been in the doctor's office and you see somebody give you those two weird sort of little house-shaped things and copy them. It's a standard. It's part of the mini mental state examination. A lot of us use it as a screening test. And it's often impaired in patients with Alzheimer's disease, but not in patients with frontotemporal dementia. It's a back-of-the-brain phenomenon. Frontotemporal dementia, as I've discussed, is a front-of-the-brain problems. Behavior, language, not these visuospatial skills, and not math. I didn't put it on here, but the other thing that differentiates Alzheimer's, one of the other things, differentiates Alzheimer's from frontotemporal dementia is in Alzheimer's disease, math tends to be pretty bad. In frontotemporal dementia, it's much better preserved on average. Again, math, because it's more of a back-of-the-brain problem, is impaired in Alzheimer's and preserved in frontotemporal dementia. Okay. Diagnostic evaluation. So the one thing you have to understand is that, and this is, I think, a really important point, that the diagnosis of frontotemporal dementia that you hear from your doctor is a clinical diagnosis, and it's not necessarily accurate. We all do the best we can. Based on these clinical observations and the clinical pattern and these tests I'll describe, we're probably accurate something like 80% of the time. In order to make a definitive diagnosis, you need the help of people like Drs. Trojanowski and Lee, who are here today, who are world experts in the pathology of it. You really need to look at the brain under the microscope. Short of that, you don't have a definitive diagnosis. As much as we like to think that we're smart and capable, we all can be wrong about this without a pathologic diagnosis. What are the tests that we do that help us in addition to the clinical examination? For my money, the clinical examination is far and away the most useful aspect of the diagnostic evaluation, far and away. I'd rather see if somebody could read kernel versus arbitrary rather than have a CAT scan or an MRI scan. But nonetheless, when we see people for whom this is a consideration, there are certain tests that are always done, or I think often done, and probably should be done. First is an MRI of the brain. So you're making sure that there's not a structural problem. An MRI scan, for those of you who don't know, everybody knows what it is, but you have to understand one thing. You can put a dead person in an MRI machine and get a normal study. Really, it doesn't tell you anything about function. It tells you about the cross-sectional anatomy. The pictures are beautiful. You get these great images of what the brain looks like, but you don't know anything about how it's working. It's a huge limitation. But we get this to make sure there's not a tumor, make sure there aren't multiple strokes, etc., infections. If you want to know how the brain is working, the best way is to examine them in terms of asking questions and do the sort of cognitive examination. But another way that gets sort of an indirect inference about brain behavior, about brain function, is the SPECT or PET scan. Now, in my view, these are overrated tests. People may differ about this, and I know there's a lot of press saying how wonderful they are. But I think they're not that useful in people with mild problems. As the disease becomes more pronounced, when the diagnosis is easy to make, yeah, the test is abnormal. But often you see people whose problems are relatively mild, for whom even these tests are really not very helpful. They're just normal or non-specifically abnormal. We often will recommend a spinal tap. Not often, but sometimes recommend a spinal tap. We often discuss a spinal tap anyway, for a number of reasons. There are some treatable conditions that one would like to be able to exclude, for which a spinal tap can be essential. Now, admittedly, they're quite uncommon. I'm talking about, lymphoma, various kinds of cancer. I'm talking about infections. If somebody's got a 3 to 4 year history, the odds of this being an infection or a cancer are really, really small. The other thing that spinal tap can get for you is that there are biomarkers of the disease, that you can measure tau levels and things like this that you'll hear more about today. And although I don't think it's quite ready for prime time, people here, Dr. Grossman, Drs. Lee and Trojanowski, Jennifer Farmer, are really, really expert at this, and they're developing wonderful measures that I think probably will be extremely useful in the future for making a more specific diagnosis. They're not ready for clinical application right yet. But these biomarkers is an area of very active research and will be quite important probably in the next few years in terms of making a more specific diagnosis. I suspect nothing will be specific except looking at the brain under the microscope, at least for the foreseeable future. Okay, forget that. Forget that, because Jennifer Farmer's going to come back. 5 minutes. Does that include questions? Okay. Okay. So, forget this is real quick because we've got 5 minutes, and that includes you guys asking questions. So, as usual, I'm talking too long. So, you can think about subtypes of semantic dementia. Of frontotemporal dementia. And in the semantic dementia type, there's a loss of knowledge of the world. It shows up primarily in language, but these are people in this condition. If you say, what's a squirrel? People just don't know. And it's not just the words. The basic concept of a squirrel, of a frying pan, of your thumb, can be lost. Primary progressive aphasia is a loss of language where the concepts tend to be better preserved. The so-called frontal variant, FTD, are people who show up with really profound deficits in behavior, in which case the language component may be absent. So they may be really quite good in language, in other words. Now, there is the frontotemporal dementia with motor neuron disease, or ALS, that I alluded to, relatively uncommon. Frontotemporal dementia with associated abnormality in chromosome 17 that Dr. Jennifer Farmer will be discussing. And there's a genetic defect. And this is actually a hereditary form of frontotemporal dementia. And forget this. So I was going to go through a couple of cases.